Hi, this is Pat Walter from the Surface Hippie website, and I'm with Dr. Barba today. He's from Rockford, Illinois, and we're at beautiful Camelback Resort in Arizona. Hi, Dr. Barba.
Hi, Pat.
Could you tell us what device do you normally use?
My normal resurfacing device is the Birmingham device. Yeah.
And when and where did you train?
I trained in Birmingham, England with Derek McMinn, and I subsequently returned to Birmingham a year later and trained with Ronan Tracy.
Okay. And about how many total hip resurfacings have you done?
I've done upwards of about 175 resurfacings currently, and I've used the Birmingham device in a total hip environment an additional 300, I would say.
Okay. Who is the best candidate for hip resurfacing? What patients are the best candidates?
I think the opportunity for resurfacing is available to young and old, really. I think patients with a good quality bone stock. I think patients with higher demands are appropriate. I think a patient that understands that having a hip replacement is a commitment and requires responsibility on their part. I think that all would be important for somebody taking on a Birmingham or really any type of hip replacement.
What are the advantages of having a hip resurfacing versus a total hip replacement?
The advantages of a resurfacing are, I think, two. I think a resurfacing gives you an option of using a metal device, and I think the Birmingham device is probably the best studied hip device in our literature, and has the potential probably to last a patient's entire lifetime. I think that device has a chance of providing the greatest range of motion and the least chance of a dislocation of any device. And in the resurfacing situation, that also gives you a significant amount of bone preservation, perhaps saving some bone for the possible future revision.
But everybody hopes, and the statistics show, a hip resurfacing could last a lifetime.
It's possible it could last a lifetime. Dr. McMinn has looked at his first 300 resurfacings. Of their ion levels are extremely low, and the revision rates are extremely low, and it does seem that this implant could last somebody's entire life.
There's been a lot of press lately about high metal ions. Is that a problem?
Yeah. I think it is a problem. I think it indicates bearing failure. It indicates a failure of the device, and certainly we want an implant that's not shedding a lot of metal. I think the Birmingham, when it's put in correctly, probably will not suffer that problem. And I think a number of us have followed our ion levels in our Birmingham patients, and we'd support what we've seen from Mr. McMinn's group.
If you thought that a patient had high metal ions, how would you test for that?
Right now, the test for metal ions is a blood test, and really the test for the failure of the implant involves the blood test, perhaps an MRI, perhaps an aspirate of the hip, and certainly a physical exam. It's unlikely that these devices are failing painlessly. The people that have failed do fail with pain.
Again, there have been a lot of articles saying hip resurfacing, it's not for women, it's not for older men, it's not for small people. What would your comment be to that?
Right. I think there's a grain of truth to everything you said, but I think every patient needs to be considered individually. Older women certainly are appropriate for it. I've done them in older women, and I think that they're as satisfied as younger men with the device. I've done them in older men, and I found some younger men that were not candidates for it. I think each individual deserves to be treated individually.
What would you tell a prospective patient about possible revisions, infections, high metal ions, metal allergies? What problems could arise?
I think metal allergy is probably an issue. I think it's an issue in probably a very small number of patients. As far as infections, I think you need to see a surgeon that has a low infection rate, and those infection rates are available. Institutions should be able to provide those, and that is very good information. I think you want to have a surgeon that has an infection rate that's certainly less than 1%, and understanding that sometimes that's institutionally related too, and an institution could provide those numbers if you're interested.
If a patient had a problem due to metal allergies or high ion levels, what type of device would you recommend for a revision?
I think the most important thing is the diagnosis. I mean, why would this individual have high ions? Would it be because the component's in bad position? Perhaps then the component could be exchanged and replaced and put in the correct position. Are there other metal generators? Does the patient have renal problems? I think you have to look at the entire situation and then decide. As far as revision components, I've revised failed metal implants with Birmingham devices. I've revised failed metal with polyethylene devices, dual mobility devices, and standard polyethylene devices. I think it all depends on the patient, bone stock, and expectations.
Could you just summarize the benefits of hip resurfacing, and maybe where do you think it's going in the future?
I think the benefit is bone preservation with the maintenance of a large femoral head that gives a full range of motion with a minimal risk of dislocation. I think the future of this technology is still very great. There is here today, I think Mr. McMinn is going to be talking about certain types of ceramic composites that even shed less metal and seem to be very durable in the short term. And I think as long as people keep chipping away at some of the weaknesses that we've had with these, we'll keep working towards the ideal device. None of these are perfect. None of these are the hip that God put in us all, and we're all just trying to achieve that perfect piece. There's a small failure rate for everything, unfortunately, and the idea in what we do is to minimize all of those risks and keep those failure numbers down as small as possible. And also we have a responsibility to look at those devices that did fail and to see why they failed, and to push our technology forward.
Well, thank you very much. I know a lot of prospective patients will learn a great deal from our interview. Thank you.
Thank you.